Hello, my name is James Vandenberg. I'm a PGY3 in internal medicine at the University of New Mexico. My case is titled Renal Failure of the Non-Crisis Variety in a Patient with Scleroderma, a recently discovered type of amyloidosis with implications for the Southwest United States. In this case, we are going to go over systemic sclerosis, secondary amyloidosis, and a newer amyloidogenic protein known as leukocyte chemotactic factor 2. This case involves a 73-year-old Hispanic female who had a history of systemic sclerosis, comorbid Barrett's esophagus, pulmonary hypertension, and also had a history of chronic osteomyelitis of the right lower extremity, which was later found to be squamous cell carcinoma, and she underwent a right BKA. This hospital admission was for a pseudomonal infection of the right BKA, and she was admitted for a debridement. During her stay, she developed rapidly progressive renal failure. Her prior baseline creatinine was about 1.3 to 1.5, and her creatinine peaked during this admission at about 5.9. The pathology report from the renal biopsy obtained during this admission is included in Figure 1 and 2, and I'll touch on that in a moment. She did have a tunnel dialysis catheter placed pending either renal recovery or the need for long-term hemodialysis, and she was started on hemodialysis during her admission. The pathology report in Figure 1 notes that 35 glomeruli were present for evaluation and 22 of them were globally sclerotic, and that there was severe replacement of the tubulointerstitium with the Congo red positive material consistent with amyloid. Mostly the focal arteries had amyloid deposition as well as the arterioles. The Congo red stain was positive predominantly within the cortical tubulointerstitium and the vessels with sparing of the medulla. Figure 2 includes the addendum from the Mayo Clinic assessment of the tissue, which notes that the tissue is involved by ALK2 amyloidosis. It also touches on the fact that this is a newer discovered protein that tends to involve the kidneys, liver, and spleen. Other research notes that it predominantly impacts the kidneys and is associated with the slower progressive renal failure. There's limited cases with which to compare, but it tends to affect Hispanics and patients of Middle Eastern descent or ethnicity. The microscopic evaluation can be seen in Figure 3, Image A and B. Image A shows the Congo red stain with amyloid deposits in the focal glomeruli and tubulointerstitium. And Image B is a board favorite of the apple green birefringent staining on the amyloid plaques, also in the focal glomeruli and the cortical tubulointerstitium. So in discussion, scleroderma renal crisis is much less common than it used to be in this population. It now occurs in about 5 to 10% of systemic sclerosis patients. Even less common, secondary amyloidosis as a cause of renal failure in scleroderma patients is not a well-described phenomenon, and I wasn't able to find other research or case reports with which to compare. Going back to scleroderma renal crisis, it's no longer the primary cause of mortality in these patients, given the advent of ACE inhibitors, which is the primary treatment. And even in patients who require renal replacement therapy for scleroderma renal crisis, research has shown that even years later, they sometimes demonstrate renal recovery. Secondary amyloidosis, on the other hand, tends to have poorer prognosis when renal replacement therapy is required. And it is associated with inflammatory conditions and malignancy, which both coincide with scleroderma. More classically, secondary amyloidosis seems to be associated with RA and malignancy, but scleroderma should be considered. There are currently over 30 proteins that are recognized as amyloidogenic in humans. The leukocyte chemotactic factor 2 amyloidosis is more recently detected. Research started to show this protein around 2008, with more research showing up around 2014. One of these more recent studies in 2016 by Larson et al. Noted that the prevalence of ALK2 among decedents in New Mexico showed about 3.1% of Hispanic decedents had the amyloid renal deposits of LECT2. Two other large case series felt that ALECT2 is likely the second or third most common form of amyloidosis, especially affecting the Hispanics in Southwest United States. There are no known biomarkers for ALECT2, so the only diagnostic method as of now is renal biopsy. So the takeaways from this case are that scleroderma renal crisis is much less common than it used to be, and that ACE inhibitors are the primary treatment. On the other hand, secondary amyloidosis is not really well recognized as occurring with scleroderma, but it should be considered given that it's associated with chronic inflammatory conditions and malignancy, both of which are common in scleroderma patients. And there are different prognostic and treatment implications between scleroderma renal crisis and secondary amyloidosis. Specifically, in terms of LECT2 amyloidosis, this is more common probably than we currently recognize in the Southwest United States and is very applicable to the region we practice medicine in. We should be considering it more often as a cause of chronic kidney disease and have a lower threshold to obtain a renal biopsy. A potential new component to the demographics of ALECT2, being Hispanic in the Southwest United States, is possibly the prevalence in patients with chronic inflammatory conditions and malignancy, like this patient with scleroderma and squamous cell carcinoma. And it's something that we should have at the forefront of our thoughts in this population. Thank you so much for evaluating my presentation virtually. I very much so appreciate it.